Okay, so let's talk about the patient with neurodevelopmental problems. Uh, okay, the case would be at the end of this chapter, inshallah. So, definitions here. Neurodevelopmental disorders are common and increasingly identified throughout a normal lifespan. You will encounter patients with them in all branches of psychiatry. They are disorders where abnormal development of the central nervous system leads to impairment in brain function. For example, seizures, which is epilepsy, abnormal movements like tics, and abnormal learning and memory, intellectual disability. The severest neurodevelopmental disorders tend to present early and are assessed and diagnosed by pediatricians. Disorders that primarily influence subtle aspects of cognition are more likely to present with behavioral difficulties in children of school age and are assessed and diagnosed by psychiatry. Because of increasing awareness of neurodevelopmental disorders in both the public and among health professionals, some people who had difficulties that were not assessed in childhood and that have persisted into adulthood are now seeking assessment for neurodevelopmental disorders as adults. The concept of neurodevelopmental disorders is evolving. Recent classification changes have given them increasing precedence with the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition, DSM-5, and the most recent draft of the ICD-11, not yet published. These including in these classification systems, including these disorders as a diagnostic category in their own right. Some disorders not historically viewed as neurodevelopmental may be categorized as such in due course. For example, brain changes in schizophrenia and bipolar disorder probably occur from a young age, but symptoms only manifest from adolescence or early adulthood. These disorders are covered in Chapter 9 and 10 in this book. Personality disorders also overlap conceptually with neurodevelopmental disorders. How is that? Both describe dysfunctional patterns of behavior with onset in childhood, causing significant impairment to the patient or others. These are covered in Chapter 17. This chapter covers the common neurodevelopmental problems that present to psychiatry: difficulties with learning, socializing, paying attention, and controlling movements. Again, we are talking about difficulties with learning, socializing, paying attention, and controlling movements. In defining disorders involving these abilities, it is crucial to recognize that performance in these areas varies normally within the healthy population. Okay, here we have a figure to talk about that. So in this figure, we have some core criteria for a diagnosis of neurodevelopmental disorders. So in A, this is the ability below average, but not significantly, so no diagnosis. While B, we are talking about ability significantly below average and significant functional impairment, so we have diagnosis here. While we can see something here like the ability is significantly below average, but no significant functional impairment, so no diagnosis would be, even if the ability is poor and more, and it is poorer actually than B. So it and of course, just to elaborate what this figure means. So this is the axis for ability, poor to excellent ability, and this is number of people, so it has the bell-shaped for normal distribution. Okay, so you may find some people with poor abilities but without diagnosis because there is no significant functional impairment. Okay, so let's get back to the text. A disorder is only diagnosed if what? If the person has characteristics that are significantly out with the typical range, and second, these characteristics are associated with functional impairment, problems in social, occupational, or adaptive functioning. So it's not just about the symptoms, it's about the impairment in functioning. Okay, clinical features and differential diagnosis. To remind you, we are talking about patients with neurodevelopmental problems in general, okay? We're not talking about diagnoses here. So, despite we will talk about them in differential diagnosis. So, let's start with this. Okay. Anyways. Okay, let's just put it here. Problems with learning. Problems with learning could be global. A generalized problem with learning new information and skills can arise through physical or mental health problems, sensory impairments, or psychosocial adversity. If these are excluded, a diagnosis of intellectual disability should be considered. So that here we are talking about global problems with learning. Okay, so a generalized problem with learning new information, okay, and of course skills can arise through physical or mental health problems, sensory impairments, or psychosocial adversity. If these are excluded, a diagnosis of intellectual disability should be considered. So let's talk about intellectual disability. Intellectual disability is an umbrella term. This umbrella term used to describe diverse difficulties that manifest as significant intellectual impairment associated with a diminished ability to adapt to the normal demands of daily living, arising during the developmental period, normally in early childhood, of course. These disorders are generally caused by an interruption in the normal development of the brain, resulting from a variety of problems. Intellectual disability is a lifelong condition. Adaptive functioning is a measure of how patients cope with activities of living, such as communication, self-care, social skills, and academic and vocational skills. Actually, I may need to, highlight these things because they are important. Okay, intellectual disability. Adaptive functioning is a measure of how patients cope with activities of living, such as communication, self-care, social skills, and academic and vocational skills. This is assessed by a thorough developmental, psychiatric, and medical history from the patient's parents and other care providers. Intellectual functioning is usually defined by the intelligence quotient. We are talking about the IQ, This can be assessed by standardized intelligence tests like Sqour intelligence scales for children, which is the WISC, and an IQ of 70 or below, which is 2 standard deviations below the mean. The mean is 100. Less than 70, we are talking. This represents sub-average intellectual functioning. It is important to remember the limitations of using standardized testing as an instrument to measure. Many standardized tests tend to be aimed at people of or around average intelligence and may be unsuitable for patients with more severe difficulties. Also, differences in native language and background, as well as sensory, motor, or communication difficulties, may lead to patients obtaining falsely low IQ scores. Therefore, patients obtaining IQ scores lower than 70 should not be diagnosed as having intellectual disability if there is no evidence of significant impairments in adaptive functioning. In addition to the impairment of adaptive functioning, patients may have clinical features associated with the specific cause of their intellectual disability, like Down syndrome, epicanthic folds with oblique palpebral fissures, broad hands with single transverse palmar crease, flattened occiput, cardiac septal defects, and so on. Other features associated with intellectual disabilities include aggression, self-injurious behavior, repetitive stereotypical motor movements, and poor impulse control. Up to a third of people with an intellectual disability have a comorbid psychiatric illness, most commonly schizophrenia in 4%, which occurs at a higher rate in individuals with learning disabilities than in the general population. Intellectual disabilities are classified as mild, moderate, severe, and profound according to the degree of intellectual and adaptive impairment. Here we have a table that summarizes the clinical features of the degrees of intellectual disabilities. So let's see. So patients with mild degree of intellectual disability, which represent 85% of cases, the IQ would be from 50 to 69. The adaptive functioning is as this. Difficulties may be subtle and difficult to identify, often only identified at a later age. Difficulties in academic work, reading and writing, but greatly helped by educational programs, usually capable of unskilled or semi-skilled manual labor, may be able to live independently with minimal support. While moderate cases, which represent 10% of cases, the IQ would be from 35 to 49. Adaptive functioning, language and comprehension limited, self-care and motor skills impaired, may need supervision, may be able to do simple practical work with supervision, rarely able to live completely independently. So just the mild degree can live independently. Moderate is not. Moderate cannot. Okay. Severe cases, which represent 3 to 4% of cases, the IQ is between 20 to 34. The adaptive functioning is as this: marked degree of motor impairment, little or no speech during early childhood, may learn to talk in school age period, capable of only elementary self-care skills, may be able to perform simple tasks under close supervision. While profound cases, which represent 1 to 2% of cases, the IQ would be less than 20, severely limited in ability to communicate their needs, often severe motor impairment with restricted mobility and incontinence. Little or no self-care, often require residential care, not just supervision. So that's sad. However, this is simplified and difficulties experienced can vary from person to person. Okay. Hints and tips. Whereas dementia describes a loss of cognitive ability already acquired, intellectual disability describes the failure to develop a normal level of cognitive functioning. However, individuals with Down syndrome are also at very high risk for developing Alzheimer's disease in later life. Okay. Communication. The terms intellectual disability and learning difficulty are often confused. A learning difficulty refers in general to any condition that impairs learning and is most often not associated with a global reduction in IQ. A specific learning difficulty is impairment in one particular type of learning, like dyslexia or dyscalculia. An intellectual disability is where learning difficulties are also associated with IQ less than 70 and impairments in adaptive functioning. Specific. So we are talking about cognitive functioning. Here we are talking about specific problems. Some disorders are characterized by the disturbed acquisition of a specific cognitive or motor function during a childhood development, like language, reading, spelling, arithmetical ability, and motor skills. If other areas of cognitive functioning are normal, a child may have a specific reading disorder. This is developmental dyslexia, but be of normal intelligence and have no problems with writing or mathematics. In some children, the consequences of the difficulty For example, school problems and bullying might lead to secondary emotional or behavioral problems. Okay. So let's talk about problems with social interaction and communication. Social interaction is one of the most complex tasks the brain has to negotiate, and many factors can influence social ability. For children, parents, health visitors, or teachers may raise concerns about a child's ability to communicate and interact socially. It is important to exclude an influence of physical or mental health problems, sensory impairments, or psychosocial adversity. Intellectual disability reduces social abilities. But if the social impairments are more marked than would be expected for the degree of intellectual disability, they can be diagnosed separately. Differentials are shown in the books, and clinical features of the neurodevelopmental causes of social difficulties are described below. Selective mutism and reactive attachment disorder are described in chapter 30. Here we have the books that illustrate the differential diagnosis for social and communication difficulties in children. First, normal for age. Second, secondary to sensory impairment like deafness. It may be caused by secondary to mental or physical health problem like depression, childhood schizophrenia, or uncontrolled epilepsy. It may be secondary to psychosocial adversity like emotional abuse. It may be caused by intellectual disability, autism spectrum disorder, Rett syndrome, childhood disintegrative disorder, attention deficit hyperactivity disorder, reactive attachment disorder, conduct disorder, selective mutism, specific language impairment, or specific movement disorder. So let's talk about some of these. Autism spectrum disorder. The three characteristics the three characteristic features of autism manifest within the first 3 years of life and include impairment in social interaction, as evidenced by poor use of nonverbal behavior, eye contact, facial expression, gestures, and failure to develop and to share in the enjoyment of peer relationships. This is first, impairment in social interaction. Second, we are talking about impairment in communication, as evidenced by poor development of spoken language, extreme difficulty in initiating or sustaining conversation, repetitive use of idiosyncratic language, and lack of imitative or make-believe play. The third is restriction and restricted stereotyped interests and behaviors. Restricted stereotyped interests and behaviors, as evidenced by intense preoccupations with interests such as dates, phone numbers, and timetables, inflexible adherence to routines and rituals, repetitive stereotyped motor movements such as clapping, rocking, or twisting, and an unusual interest in parts of hard or moving objects. So we have impairment in social activity, impairment in communication, and restricted stereotyped interest and behaviors. In addition to these diagnostic features, patients may also exhibit behavioral problems such as aggressiveness, impulsivity, and self-injurious behavior. Although children with mutism can be of normal intelligence, 50% have significant intellectual disabilities. Epilepsy develops in about 25 to 30% of cases. Asperger's syndrome or high-functioning autism is a subtype of autism where there are no significant abnormalities in language acquisition and ability or in cognitive development and intelligence. Although Asperger's syndrome is a diagnosis in ICD-10, it is not included as a separate diagnostic category in the DSM-5 or in the latest draft of ICD. The term pervasive developmental disorder is now used synonymously with autism spectrum disorder, with pervasive developmental disorder. Okay. This is good to know. pervasive developmental disorder. Okay. Rett syndrome. Rett syndrome, which has almost only been seen in girls, is caused by mutations in the gene MECP2 located on X chromosome and can arise sporadically or from germline mutations. It is initially characterized by an apparently normal antenatal development with a normal head circumference at birth, followed by an apparently normal psychomotor development in the first 5 months after birth. From 6 to 2 years of age, a progressive and destructive encephalopathy results in a deceleration of head growth, loss or lack of development of language, and loss of purposeful hand movements and fine motor skills, with subsequent development of stereotyped hand movements, midline hand wringing. After a decade, most girls are bound to a wheelchair with incontinence, muscle wasting and rigidity, and almost no language ability. Another diagnosis is childhood disintegrative disorder, which is Heller syndrome. Childhood disintegrative disorder. This disorder, which is more common in boys, is characterized by about 2 years of normal development, followed by a loss of previously acquired skills like language, social and adaptive skills, play, bowel and bladder control, and motor skills before age 10 years. It is also associated with an autism-like impairment of social interaction, as well as repetitive stereotyped interests and mannerisms. Thus, after the deterioration, these children may resemble autistic children. What about adults? In adults presenting with social difficulties, the main differentials are shown in the box below. Here we have some differentials for social and communication difficulties in adults. We've talked about these difficulties in children. In adults, it may be within normal range. It may be because of intellectual disability, because of autism spectrum disorder, because of personality disorders like schizoid, schizotypal, obsessive compulsive, anancastic, emotionally unstable personality, dissocial personality, and so on. Secondary to other psychiatric disorder like social phobia, generalized anxiety disorder, or depression, or even negative symptoms of schizophrenia, of course. Maybe because of brain injury, traumatic cerebrovascular accident, infection or inflammation, or because of neurodegeneration like in dementia. So, it is paramount to take a history of the time course of difficulties. Have they been present from a young age or only since adulthood? Patients themselves usually struggle to provide an objective account of this. So it is essential to obtain a collateral developmental history from someone who knew the patient well as a child. This can be a parent, a teacher, an old sibling, or in written form, for example, school reports. The validity of any diagnosis of this sort in adulthood increases the number of sources of collateral information available. If impairments in communication and social abilities have had onset or significantly worsened in adulthood, then it is important to exclude other conditions that could have caused this. For example, a traumatic brain injury, frontotemporal dementia, a depressive episode, or schizophrenia. Anxiety and depression are often comorbid with autism in adults. A primary diagnosis of social anxiety can be distinguished from an autism spectrum disorder in that there should be no associated problems in communication or restricted interests, and social abilities should be intact, for example, able to make normal eye contact. In generalized anxiety disorder, anxiety covers many areas, not just social situations. Personality disorders can be distinguished from autism by the associated features. For example, finding little pleasure in anything in schizoid personality disorder, magical thinking in schizotypal personality disorder, a desire for perfection in anancastic personality disorder, feelings of emptiness and frequent self-harm in emotionally unstable personality disorder, and the ability to read social situation to disregard social obligations in dissocial personality disorder. Clinical features of autism spectrum disorders in adults versus children are shown in the table below. So, for about the impaired social interaction, in childhood there would be the child would be not interested in peers and with little eye contact, while in adulthood not able to make small talk, doesn't pick up social cues. In the domain of impaired communication, in childhood it may be as delayed speech. In adulthood it would be something like pedantic, overly formal use of language. In the domain of restricted stereotype interests and behaviors, in childhood it would be intense interests in physical aspects of objects or numbers, lining up milk bottle tops, inflexible adherence to routine, repetitive movements like clapping or rocking. In adulthood it would be something like intense interest in objects or numbers, often enjoyment gained from categorizing or collecting, like listing train timetables. Inflexible adherence to routine and repetitive movements, less common in adulthood. Okay, so that's it. So we were talking about, yeah. In adults presenting in adults presenting for the first time with a possible diagnosis of autism, intellectual disability is rare, and impairments tend to be milder than those diagnosed in childhood. Because difficulties are likely to be at the milder end of the spectrum, it is very important to clarify the severity of the person's difficulties and the degree to which they impact their life. For example, problems in initiating or sustaining employment, education, and or relationships. Your own mental state examination and a collateral history are crucial. Not everyone who has difficulty in interacting has autism or any other psychiatric diagnosis. So, let's talk about problems with attention. In children, in a child described as paying poor attention, it is important to exclude an influence of physical or mental health problems, sensory impairments, or psychosocial adversity. Intellectual disability reduces the ability to pay attention. But if this is more marked than would be expected for the degree of intellectual disability, it can be diagnosed separately. Differentials are shown in the books, and the clinical features of the key neurodevelopmental cause of inattention, which is ADHD, is described below. So let's go to the box of the differentials. Here we have the differential diagnosis for attention difficulties in children. First, it may be normal for age or secondary to sensory impairment like myopia, secondary to mental or physical health problems like anxiety and restlessness due to pain, secondary to psychosocial adversity like hunger, intellectual disability, attention deficit hyperactivity disorder, conduct disorder, reactive attachment disorder, Tourette syndrome or dyskinesia, specific learning difficulty. Okay. So, let's talk about them. So, what about these differentials? ADHD would be described below. Conduct disorder and reactive attachment disorder are described in chapter 30. They can be distinguished from ADHD in that in conduct disorder, the child breaks rules deliberately rather than impulsively, and resists completing tasks because they do not wish to conform rather than being unable to sustain attention. In reactive attachment disorder, a child may appear socially disinhibited, as with ADHD, but with struggle to form any sustained relationships, which is not the case for ADHD. Okay, hints and tips. Sensory processing abnormalities such as hypersensitivity to sound or touch are common in autism spectrum disorders and attention deficit hyperactivity disorder. The presence of such abnormalities increases the likelihood of the neurodevelopmental diagnosis, but is not required for a diagnosis. Okay. So let's talk about ADHD. Problems in the three domains below should be present, causing significant functional impairment in at least two settings, like school and home, for at least 6 months. What are these fields or, functional fields? First, impairment in attention, impaired attention. Second, impulsivity. Third, hyperactivity. So what about impaired attention? Rather than failing to pay attention, children pay more attention to more cues and are unable to eliminate unnecessary cues. This may manifest as difficulty completing work or play tasks, not listening when being spoken to, being highly distractible, moving from one activity to another, reluctance to engage in activities that require a sustained mental effort like schoolwork, unless very interested in the task, like video games, being forgetful or regularly losing things. What about impulsivity? Children with ADHD are unable to suppress impulses and therefore respond to all impulses. This may manifest as difficulty awaiting turn, interrupting others' conversations or games, or prematurely blurting out answers to questions. Hyperactivity. Children with ADHD fail to pause and to consider options and consequences prior to acting. This may manifest as restlessness, incessant fidgeting, running and jumping around and in inappropriate situations, excessive talkativeness or noisiness, or difficulty engaging in quiet activities. So, impaired attention, impulsivity, and hyperactivity. Hints and tips. When assessing a person's ability to concentrate, remember to take their developmental stage into account. A rule of thumb is that a preschool child would be expected to be able to concentrate for at least 3 minutes, a child at primary school for at least 10 minutes, and an adolescent for at least 30 minutes. In adults presenting with attentional difficulties, the main differentials are shown in the books, which is here. Okay, so here we are talking about differential diagnosis for attention difficulties in adults. It may be within normal range, it may be secondary to a substance abuse, intellectual disability, attention deficit hyperactivity disorder, personality disorder like emotionally unstable or dissocial personality, secondary to other psychiatric disorders like bipolar affective disorder or generalized anxiety disorder or even depression, brain injury, traumatic cerebrovascular infection or inflammation, and neurodegeneration like in dementia. Okay. So, as with social impairments, it is paramount to take a history of the time course of difficulties with a collateral developmental history from someone who knew the patient well as a child, or contemporaneous documentation such as school reports. If impairments in attention have had onset or significantly worsened in adulthood, then it is important to exclude other conditions that could have caused this. For example, traumatic brain injury, dementia, a depressive episode or anxiety. Bipolar affective disorder can present with mood instability, similar but not more severe than that seen in ADHD. The use of substances, particularly amphetamines, must be excluded, of course. Emotionally unstable personality disorder overlaps with ADHD in terms of impulsivity and rapid emotional variation. However, ADHD is not associated with feelings of emptiness or self harm. Disocial personality disorder overlaps with ADHD in that both are associated with low breaking and often found in prison populations. However, in ADHD, the offenses tend to be committed impulsively, whereas in dissocial personality disorder, there is more likely to be premeditation. Okay, to be premeditation. Okay. Hints and tips. The symptoms of neurodevelopmental disorders overlap with the symptoms of many other psychiatric disorders. And it's important to be aware of the possibility of missed neurodevelopmental diagnosis. This applies particularly to patients with atypical patterns of symptoms or response, like rapid cycling bipolar, treatment resistant depression, and to patients with several diagnoses, none of which quite seem to fit. Clinical features of ADHD in adults versus children are shown in Table 18.3. Let's talk about that. So, these are the domains of symptoms in attention, impulsivity, and hyperactivity, and in childhood and in adulthood. The attention in childhood would be something like poor self-organization, like lose school jumper, needs instructions repeated, careless mistakes in schoolwork. While in adulthood, it would be something like frequently loses important items like keys, wallet, phone, struggles to complete administrative tasks. Impulsivity in childhood would be something like shouts out answers to questions, difficulty waiting turn, easily led, risk taker. In adults, something like makes reckless decisions, completes others' sentences, avoid quining. Okay, the hyperactivity in children, it's like this: moves around inappropriately, excessively talkative, goes off on tangents. Okay, in adult it would be something like movement less of a problem in adulthood. Okay, movement less of a problem in adulthood. May avoid situations where sitting still is expected, like cinema or theater. Over talkative with tangential conversations. Okay, so that's it. In adults presenting with for the first time with a possible diagnosis of ADHD, impairments tend to be milder than those diagnosed in childhood, of course, because difficulties are likely to be at the milder end of the spectrum. It is very important to clarify the severity of the person's difficulties and the degree to which they impact their life. Your own mental state examination and collateral history are crucial. Not everyone who gets bored easily has ADHD or any other psychiatric diagnosis, of course. So that's it. Okay. Here we have things about mental state abnormalities in people with neurodevelopmental disorders like intellectual disability. Typical findings on mental state examination would be something like very dependent on severity of disability, of course. Struggles to understand your questions, gives short answers with limited vocabulary, dysarthric. In autism spectrum disorder, you can find reduced eye contact, does not pick up on social cues when it's the end of the appointment. Speech may have limited intonation, be oddly accented, or be unusually formal or pedantic. Talks excessively about topics of particular interest to them, does not take turns as in a normal conversation, affect unreactive or odd, not able to use facial expression to communicate naturally. ADHD, adults may be fidgety, children may get up from chair, play noisily with toys, run around waiting room, shout. Person may talk at length in a tangential fashion, they may speak over you or finish your sentences. Information may need to be repeated, easily distracted by external noises like traffic or distant telephone. In Tourette's, you can see texts featured of comorbid attention deficit hyperactivity disorder. Anyways, okay. So let's continue with problems with controlling okay, we are done with social problems. Now we are talking about problems with controlling movements. Abnormal movements can result from a diverse range of problems. For example, orthopedic, rheumatological, neurological, or nutritional problems. Those covered here are those that are thought to be due to a problem with cortical processing of the coordination of movements, rather than a problem with the mechanics of a movement. In this table, we can find the types of motor abnormality, tics, stereotypy, and mannerism. Tic is something like quick, sudden movement arising unpredictably. Okay. Quick, sudden movement arising unpredictably, generally occurring for a brief time, often stereotyped, the same movement, and recurrent but not rhythmic. Suppressible and suggestible, usually occurs at age 5 to 7 years. An example for that: eye blinking, mouth twitching, grunting, simple or shouting out words, squatting, twirling while walking, making obscene gestures. This is complex. So we have simple tics and complex tics. Stereotypy, on the other hand, is identical non-functional movement repeated many times, arises in a fixed, predictable manner. Person can be distracted from movement but cannot voluntarily suppress. Usually occurs by age 2 years, like hand flapping, twisting, rocking, head banging, grimacing, humming, and grunting. Mannerism is goal-directed movement that individual performs frequently in a way unique to them, under voluntary control, may be bizarre if in response to delusional ideas, like twirling hair, rolling eyes, clearing throat, common part of personality maybe, jerking head, twiddling finger movements. This is rarer and bizarre. So, tics, quick, sudden, suppressible, stereotypy, non-functional movements that are not suppressed voluntarily. That can be expected, of course. Mannerism is something else. It is voluntary somehow. Okay. Okay, let's talk about developmental motor coordination disorder, specific developmental disorder of motor function. This disorder, developmental motor coordination disorder, is characterized by significantly impaired gross and fine motor skills in the absence of intellectual disability, significant to cause marked functional impairment. For example, very slow or inaccurate when catching a ball, walking or riding a bike. This is gross. Or using scissors, cutlery zippers or pins. This is fine. This generally improves with age. Okay. Tourette syndrome. Tics are sudden, repetitive, non-rhythmic motor movements or vocalizations. They are usually preceded by a premonitory feeling of discomfort. They are involuntary, however, they can be voluntarily suppressed, although this can be very difficult, like trying to suppress the urge to sneeze. They are also often suggestible. It means that they can be provoked by discussing them or by observing others' tics, and become more prominent during times of stress. Tics are divided into simple motor tics, simple vocal tics, complex motor tics, and complex vocal tics. Simple motor tics like eye blinking, neck jerking, or facial grimacing. Simple vocal tics like grunting, coughing, barking, or sniffing. Complex motor tics like jumping, touching self, copropraxia, which is using of obscene gestures, or complex vocal tics like senseless repetition of words, or coprolalia, which is the use of obscene words or phrases. Tourette's syndrome is characterized by the presence of both multiple motor tics and one or more vocal tics for more than 1 year. The motor tics usually present by age 7 years, although tics can present as early as 2 years of age. Obsessive compulsive disorder and ADHD are common comorbidities. Okay. So let's talk about the assessment for patients with neurodevelopmental problems. Okay, here we have a figure to consider the whole approach. Patients may have problems with learning, social interaction, communication, attention, or movement control. So we take history from patient. We consider screening tool in adults like AQ10, and we consider diagnostic interview guide like the DIVA. Then we have some observation of patient in clinical setting. We consider standardized assessment like ADOS. Then we should elicit collateral history covering developmental and current difficulties. You may consider construct questionnaires like Connor's scale for ADHD or social responsiveness scale for ASD. In children, speak at carers at home and carers at school. In children, speak to carers at home and carers at school, like teachers. In adults, speak to parent, former teachers, or get school reports. Also, ask to speak to parent, someone who know patient well now. Then to the observation of patient in educational setting. This is for children only. After that, you should exclude difficulties within range of normality. This is important. These symptoms may be normal. You should exclude difficulties without associated functional impairment, because that would not be considered as a disorder. You should exclude difficulties present in only one setting, and difficulties with onset in adulthood, and difficulties due to other causes like sensory impairment, other psychiatric disorder, physical health problems, or psychosocial adversity. Then you consider making a diagnosis of neurodevelopmental disorder, of course. So starting from history, the following questions may be helpful in screening for the disorders below. So, for learning difficulty, you may ask, do you have problems looking after yourself? Do you have problems with reading or writing or maths? It is difficult to understand what people are saying. Is it difficult to understand what people are saying? For autism spectrum disorder, you can ask, what is a friend? What are your hobbies? How would you know if someone was sad? What would you do if someone was sad? Can you make small talk? For ADHD, you can ask, when did you last lost your bank card, phone, keys? Do you often make careless mistakes? Have you been told you don't listen? Are you distracted easily by background noises? Are you fidgety? What is it like inside your head? And people with ADHD will often answer that it is busy and chaotic. For Tourette's syndrome, you can ask, do you find yourself making pointless movements or sounds? Do you get an urge beforehand? Can you suppress the urge, like with a sneeze or an itch? What happens if you suppress it? People with Tourette's syndrome report discomfort, of course. Okay. For examination, you assess for physical signs suggestive of a syndromic intellectual disability, for example, large ears in Fragile X. You assess for physical disorders that could cause the presenting complaint, of course. And you complete a mental state examination focusing on behaviors suggestive of the neurodevelopmental disorder you are assessing for. What investigations should be done? No specific investigations are required to make a diagnosis of a neurodevelopmental disorder. Genetic testing is increasingly used in identifying the cause of intellectual disability, but it's not required for the diagnosis. Some investigations may be useful in excluding differentials or in identifying suspected comorbidities, for example, an EEG in someone with repetitive movement to exclude epilepsy, thyroid function in someone who has become restless and lost weight to exclude hyperthyroidism. Let's talk about this case. Joan, aged 9 years, was assessed by the child and adolescent mental health team after his teacher told his parents she thought Joan might have attention deficit hyperactivity disorder. She had noticed that he was a bright child but made a lot of careless mistakes in his homeworks. Okay. Which he often forgot to bring to school. He had always been very talkative, which initially endeared him to his peers. But lately he had fallen out with some friends as they said he never let them get a word in. He had also always been an active boy and had been picked for his school football team. However, the coach had dropped him after John failed to notice the ball coming in his direction on a number of occasions, seemingly starting off into space. Okay. His high activity levels were becoming increasingly noticeable as he got older, and his peers became better able than him to sit through a class. John's parents were initially surprised by the suggestion, but on reflection agreed that he often did things without thinking. He broke an arm last year after leaping out of a tree, and they had never considered going to the cinema as a family because they knew John would not be able to sit through a film. There were no concerns that they were not looking after John well. John told the psychiatrist that he generally felt cheerful, had no physical problems, and did not have any problem seeing or hearing. In fact, he thought he had extra good hearing because he seemed to notice things other people did not, such as bird calls outside the classroom. So let's discuss that. So John is likely to meet criteria for ADHD. Although a school observation needs to be arranged, he has problems maintaining attention. For example, completing schoolwork, remembering homework on the football pitch. Impulse control, like talking over friends, jumping out of trees, and hyperactivity, like not be able to sit through a class or a film, that are more severe than those seen in his peers. He may also have sensory hypersensitivity to noise. His difficulties occur in multiple settings. These problems are causing him functional impairment in educational attainment, socializing, and risks to his person. There is no evidence of intellectual disability, sensory impairment, psychosocial adversity, or physical or mental health problems. So we are talking about ADHD. Okay, now you can read chapter 29 about neurodevelopmental disorders and their management. So, to the summary of this chapter. Chapter summary. Neurodevelopmental disorders are disorders where abnormal development of the central nervous system leads to impairment in brain function. To be classed as a disorder, an impairment in brain function should also cause an impairment in social, occupational, or adaptive function. Intellectual disability results in an IQ less than 70 with impairments in adaptive functioning. Autism spectrum disorders cause a triad of impairments in social interaction, communication, and restricted or repetitive behaviors, or interests actually. Attention deficit hyperactivity disorder causes a triad of impairment in attention, impulsivity, and hyperactivity. So, impairment in attention, impulsivity, and hyperactivity. Tourette syndrome causes a combination of motor and vocal tics. And that's it. هذا والله تعالى أعلم وصلى الله وسلم على سيدنا محمد وعلى آله وصحبه أجمعين.